Okay, so as Francisco was saying, my name is Kyle Vader. I'm a physiotherapist. I currently work in Kingston, which is about 2.5 hours from here, and where I specifically work is in an academic outpatient hospital. And although I don't work specifically in the context of HIV, I do encounter several patients who come through who happen to be living with HIV. I currently work in a chronic pain program, and today what I'm going to be speaking about is really the idea of establishing, but also the preliminary aspects of evaluating a new model for self-management that we're kind of calling a blended model between self-management and rehabilitation. So no conflicts to disclose. So it's been neat. I hear kind of even what's been talked about already. We're hearing this idea of pain coming up a lot as a common thing that people are presenting to us with when we're providing care for them. So I thought it's helpful just to kind of start off with, like, what is pain? We probably all experienced pain in our life, but it can be different for different people. So we know that pain, it's an unpleasant sensory but also emotional experience associated with actual or potential tissue damage. And the second point there is important because although unpleasant, acute pain, so pain that comes on when we've done something that's maybe not as helpful, is actually really, really important for survival. It forces us to seek help. It causes us to avoid doing certain things that might not be good for keeping us alive in the long term. But it can also tell us to rest an injured area if it's warranted. So chronic pain, and that's really what I'm going to be speaking about today, is a bit different. So this is pain that's lasted for longer than 3 months, and oftentimes when we're talking about chronic pain, we're not as worried about the state of the tissues or the bones or joints or ligaments. What we're actually thinking about is how is the nervous system involved, and how can we use self-management strategies to help people in feeling more confident in managing their pain. Importantly, chronic pain can impact a lot of different things. I think we've spoke about it already, but frailty, depression, cognitive impairments, falls, poor sleep quality. I'm just going to quickly put this up here, talking about what's the biopsychosocial model of pain. I'm really interested in this, and although I've broken it up into different circles here, why I put the asterisk next to the biopsychosocial is that's one word. We really can't divide it up, but as best as we can think of it of what are the biological factors, what are the psychological factors, and what are the social factors, but really this is a combination of all of these together, and it's a complex interaction. And I think it speaks to why rehabilitation providers, but also kind of healthcare providers as a whole, we can all have a role to play here, but it's figuring out how, when, and what ways we can do this. So quickly, just on the landscape of chronic pain in Canada, I'll just focus on the bolded point there. So it's particularly common. 15 to 19% of Canadian adults live with chronic non-cancer pain. Based on the nature of the talk today, I just did a little bit of a search on what is the context of chronic pain among people living with HIV. And again, particularly common, peripheral neuropathy in one study was found to affect 50 to 60% of people living with HIV. Really, really common. The second study that I looked at here, and this was of particular interest to me because a lot of the people who I work with on a daily basis in Kingston are people who have lots of complexities in their lives, and how can we as rehabilitation providers meet them where they're at? And it was talking about the idea of looking at a cross-sectional study of people who were socioeconomically disadvantaged and were also living with chronic pain. 8.2% reported mild pain, 38.1% reported moderate pain, and 53.7% reported severe pain. So pain is a really common issue, and oftentimes it's not being talked about. I also like to add this on here because I like to think of pain management as, sometimes I call it the 3 Ps. So there are psychological strategies, there can be pharmacological strategies, and there can also be physical strategies, if I didn't include that. And really what I want you to take away from this picture here is that different people are going to need different proportions of this. I don't think that everyone needs to get moving more. Some people are already moving a lot, and maybe they need other strategies like pharmacological or psychological strategies, whereas for other people, maybe we're going to put more of an emphasis on physical strategies and maybe less on pharmacological and psychological. So it's really about tailoring this to the person that's in front of you, and although we have these really great conceptual models that can help us out, we really need to tailor what we're doing to the individual. So what's the role for rehabilitation providers? These are the things that I try and work on a daily basis, but still lots of work here to figure out what does this mean, and what I think is neat in the context of people living with HIV, particularly those who are aging with HIV, is how can we tailor these interventions specifically for certain populations? So really focusing on the idea of functional restoration. People often talk about that people don't suffer from pain only because of the pain itself. They suffer from pain because they can't do the things that they want to be doing in their lives. So as rehabilitation providers, I think that's where we have a really, really key role when we can come in and help people. Also around the idea of pacing and goal setting. Graded physical activity. As a physiotherapist, I focus a lot on this. Pain neuroscience education. There's a lot of really cool work coming out by Lorimer Mosley, who's a physiotherapist in Australia. I'm not a religious guy, but if I was to be religious, I would worship him, I always say. A lot of really cool work around pain neuroscience education, so check that out if you're at all interested. And then the idea of self-management support. So specifically speaking about the model that I've been working to develop in Kingston, it's important to note that we're at an academic center, we're an outpatient hospital, and I have the luxury of working with a multi or interprofessional team of psychologists, physicians, social workers, occupational therapists, physiotherapists. So we have the luxury of having people on our team. But I always like to say that even in a place where we're all physically in the same place, there are challenges of providing interprofessional care even when we're all there and in the same place. So it's not an easy thing. And what I talked about really from this picture is the idea of we have, traditional rehabilitation interventions and self-management interventions, and how can we kind of fuse those two? And what does that look like? And what does that mean? And how can this offer kind of exciting opportunities in the context of chronic disease management? So specifically of how we went about developing our self-management interventions. So we tried to draw on the literature, so we did a scoping review. We also did an environmental scan of services that were available in our region. And then we also worked with the School of Rehabilitation Therapy at Queen's University in Kingston to develop a logic model of creating this new way of delivering a self-management intervention. What are our goals? How are we going to measure it? And who's going to be involved? But you can also look that there were lots of other things here that kind of muddied the water. Some things were more pragmatic, like operating budgets, human resources, clinician expertise, our catchment area. We have quite a rural population that comes into Kingston. How do we manage that piece? Do people want to come in person, as Claire was mentioning? Do people want to have this delivered remotely? Do they want to be able to telemedicine in? And we're still figuring that out now. So again, this was a really iterative process. We worked really closely with Catherine Donnelly, an occupational therapist and associate professor at Queen's University, and she really guided us, particularly around the idea of community-based programs. And although we're delivering our chronic pain self-management program at an academic outpatient center, how can we really look forward to how could this be implemented in the community and not only in a very structured and regimented academic center is a goal of ours. So this is a quick schematic of what's the self-management intervention look like. So it's currently a 12-session program. It happens one time per week for 3 hours. They come in for 12 weeks, and these are people who are living with chronic pain, not specifically in people who are living with HIV, although the area that I work in the hospital, our infectious disease clinic is on the same floor, so we have quite a few of the same patients that come through. So they come in for an initial assessment, and what I found has been really helpful in my own clinical experience is how ready are people to engage in self-management? And I think that's a really important piece to think of, because we can have these really effective interventions, but also who are the people that are going to benefit most from this? So they come in for a readiness assessment, then they have 12 sessions that are delivered. Again, we're lucky in the fact that we co-facilitate this by an occupational therapist, a physiotherapist, and a psychologist. So we have 10 patients that come in, and we kind of co-facilitate this, and we kind of describe this as the Cadillac version of our self-management program, but we are also seeing of how can we deliver this with maybe only one provider so that it's not as resource intensive. We then conduct follow-up at 1 and 3 months. Because we're seeing that if we invest a lot of time to get people feeling more confident in managing their pain, we also want to make sure that they don't feel as though they're being dropped after they've finished this quite intensive program. So we really want to work on supporting people, but also importantly, how can we work with primary care providers so that they feel that they can continue to support the people that they're working with, even when they're not in our doors anymore. So the goals of our self-management program, specifically in the context of pain, the first one is around the idea of understanding pain neuroscience. What I think is actually really neat is that people can, the more people understand pain, the better they can actually manage it. Thanks. We wanted to improve emotional coping, promote participation in activities that are consistent with their personal values and what's important to them. Importantly, how can we get people using physical activity as a strategy that can actually help to manage their pain and maintain their function versus only having it flare up their pain. And finally, increase their confidence in using self-management strategies. We use lots of different outcome measures here, and I think this speaks to the idea that pain is a biopsychosocial concept, and only giving a numeric pain rating scale of 0 to 10 is not always going to capture the complexity of someone's pain experiences. We look at different things of how this impacts function. A neat one that we've trialed is the Pain Stages of Change questionnaire, looking at people's readiness based on the trans-theoretical model to engage in self-management behaviors, but lots of other things here. Almost done, just I'm seeing my time. Implementation, challenges, and successes so far. So our challenges have been really around the idea of how can we screen people who are going to be most appropriate? What are the appropriate measures to capture the work that we're doing and the benefit that patients are telling us they're experiencing? Interestingly, so far, based on our preliminary results, we're hearing a lot of really great qualitative feedback, but what shows up in our outcome measures can sometimes tell a bit of a different story. The last piece around successes, we're really trying to engage with community-based programs like the YMCA and the City of Kingston to see how we can improve access to this type of services, not only at our hospital. A couple things here which I think just speak to the participant feedback so far. The idea that I changed my routine and got out of a rut. I tried things that made me feel uncomfortable, and some of these things were really helpful, which I think speaks again, as we've talked about, to that idea of the social piece of group-based interventions, and that us as healthcare providers, we don't have all the answers, and people with that lived experience can have a lot of value in helping each other. Our next steps are to conduct a more formal program evaluation, and that is that. Thank you.
Thank you.